Hi, everyone. Good morning, good afternoon, good evening, depending on your time zone. Thank you so very much for joining us today, the 18th of November, 2025, for the World Antimicrobial Awareness Week, organized by the Global Health Network. We are very glad that you could make it, and we really do appreciate your presence today. So we'll just give a couple of seconds for our colleagues in the waiting lobby to join us, and then we will make a start. All right. Once again, good morning, good afternoon, good evening, depending on your time zone. My name is Godwin Payos Ohemo, and I work as graduate assistant at the Antimicrobial Resistance Knowledge Hub of the Global Health Network. And today I'm going to serve as the chair of today's meeting. We are gathered here to commemorate the World Antimicrobial Awareness Week via a webinar. And this webinar is themed One Health in Action, African strategies to tackle AMR across human, animal, and environmental health. We are very glad that you're here. And as we start, I just want to quickly make this housekeeping announcement. This webinar is being recorded and it will be shared on the Global Health Network platform. Due to the number of participants on the call, your camera and microphones are disabled. Please, we request that you use the chat box to introduce yourself and let us know where you are joining us from. And should you have any technical issue, you let us know via the chat box. Each speaker is going to make their presentation, and once they are done, we are going to have a Q&A session. And for the Q&A, in case you have a question you would like to ask the speaker, please you use the Q&A feature to post your question. You can post your question anonymously, or you can post your question with your name and affiliation attached to it. We have this Q&A session mapped out so that everybody can flow along and have their question answered. So these are the persons who are joining us for today. We are very glad that you all made our time to register for this event and also to be present. We couldn't have done this without you. So from the very depth of our heart, we are saying thank you so very much. So quickly for the panel and agenda for today, I will serve as the chair of today's meeting. My name is Godwin Payos Ohemo, and I work as graduate assistant at the Antimicrobial Resistance Knowledge Hub and Community of Practice of the Global Health Network, University of Oxford. A welcome address will be given by my colleague, Adam Dale, who works as the Knowledge Exchange Lead of the Global Health Network. After the welcome address, we are going to have our first presentation, and which will be delivered by Dr. Babafela Awosili, Assistant Professor, Texas State University. And then we'll have the second presentation titled The Impact of Operational Research as a Tool to Tackle Antimicrobial Resistance with a One Health Approach. This will be delivered by Dr. Robert Terry, Manager of Research Policy, TDR WHO. And then we'll have the third presentation that will be given by Dr. Kip. And then afterwards, we'll have a collective Q&A session where you are free to ask your question. Then we'll have a closing remark and every other thing will flow along. So please do well to use the chat function to introduce yourself. We really would love to know where you are joining us from. And if you have any technical issue, please let us know. My colleagues are on the call and they will be able to lend their help to solve whatever issue that you might be having. So without wasting any bit of our time, please permit me to honorably invite to the fore my colleague Adam Dale as he make the opening remark so that we can start. Adam, if you're ready, we are ready. Over to you.
Thank you, Hamo. And yeah, I'll be very quick, really, just to say thanks to everyone for coming and to welcome you all to this webinar, and which is the first of a series of webinars we have this week across the Global Health Network, organized as part of this World Antimicrobial Awareness Week. There's always a theme to these awareness weeks. This one's Act Now, Protect Our Present, Secure Our Future. I think the thing there is underscoring that need for that kind of bold, united action to address AMR. So the focus we have, the united action we have, is drawing on this fantastic, diverse community we have across the AMR Knowledge Hub and wider across the Global Health Network of more than 1 million members, people who are joining us today. the webinars are focusing on this year on Africa, Asia, and the MENA regions, and looking at AMR from a One Health perspective, particularly. So recognizing that interconnectedness of environmental, animal, and human health is really key to a kind of coordinated action for AMR, as is this global concerted effort to work together to share knowledge and best practice across sectors and disciplines, which is really the essence of what we do on the Global Health Network. And so I'd just like to thank all the speakers who are joining us today from all time zones and across the world to look at strategies today specifically across Africa to tackle AMR. Thank you, Heman and Kikishan, for organising this event, and particularly for all of you who are joining us. It's great looking at the map every time we do these webinars to see where people are coming from. And do please continue to introduce yourself in your chat and use those comments and post your questions in the Q&A for the speakers, because we really do want to hear from all of you today. So that's what I wanted to say. I'm really looking forward to this event. And Heman, I'll pass back to you to introduce our first speaker.
Thank you so very much, Adam. That was great. Colleagues, we are very glad that you are with us. And please, we still encourage you to use the chat box to introduce yourself to us. We'd like to know you. We'd like to know where you are joining us from, and we'd like to connect with you. So, ladies and gentlemen, without wasting any bit of our time, we are going to jump in straight to the first presentation for today, which is going to be delivered by Dr. Babafela Awosile. The topic of his presentation is Antimicrobial Resistance Drivers in Africa and Plans for Action at the One Health Interface. Please permit me to introduce him to you before he takes the floor. Our first speaker for today is an assistant professor of epidemiology. He grew up in the southwestern region of Nigeria. He earned his Doctor of Veterinary Medicine degree and Master of Veterinary Science in Veterinary Public Health and Preventive Medicine from the Federal University of Agriculture in Abeokuta, Nigeria. He earned his PhD in epidemiology from the University of Prince Edward Island and a graduate certificate in One Health from the University of Saskatchewan in Canada. He has worked as a research fellow, university lecturer, postdoctoral fellow, and health information specialist in Nigeria and Canada. His instructional focus is on the application of epidemiological principles in veterinary practice and promotion of One Health. His research uses epidemiological, genomic tools, and One Health approaches to understand occurrences of infectious diseases, especially antimicrobial resistant bacteria, and the application of mitigation strategies to reduce the occurrences. He is a diplomat of the American College of Veterinary Preventive Medicine, both preventive and medicine and epidemiology specialties. He is a member of the Association for Veterinary Epidemiology and Preventive Medicine, the Conference of Research Workers in Animal Diseases, and the chair of the One Health Committee of the Texas Veterinary Medical Association. Ladies and gentlemen, please join me in welcoming Dr. Babafela Awosile as he makes his presentation. Prof, if you're ready, we are ready.
Right, thank you very much. I'm going to share my screen.
Please do.
So can you see my screen in the presenter mode?
Yes.
All right, thank
yes,
you
we
very
can.
much. Right, so I just want to thank you for this opportunity to kind of, share some of this presentation with everyone. And whatever you're joining for, I really appreciate your participation in this talk. So for this presentation, I give some background with AMR within the context of One Health in Africa and also on a global level, and then try to identify some of the driving factors of AMR at One Health Interface in Africa and around the world, and then kind of provide some of the mitigation strategies that are currently ongoing, and as well as summarize my talk within the specified time. So, I mean, I'd like to start first with this slide. I mean, most of the time when we talk about One Health, in most cases, we usually look at it from infectious disease point of view. I mean, just to kind of, let us know in this 21st century, the paradigm has kind of shifted. So in the modern era, we're talking about a lot of complex issues, a combination of different, both infectious and non-infectious occurrence. And of course, within that framework and new paradigm, we have AMR across One Health, whether within the human and also animal and also environmental domain. So it's very important to clearly hear on that. When we talk about One Health, it's no longer about infectious disease or zoonotic disease. We make it more complex and also intertwined and interacted across both infectious and non-infectious disease landscape. So what is antimicrobial resistance? I kind of provide a baseline understanding of that. So that's AMR evolved or results as a result of the fact that microbes evolve mechanism to protect them from effect of antimicrobials, right? So, I mean, of course, there are a lot of factors that bring about development and dissemination of AMR, but I like to kind of stick to this two important factor, which is indiscriminate use or non-judicious use of antimicrobials. And in most cases, within the microbe cell, dissemination of different resistant genes between different bacteria contributing to the occurrence of antimicrobial resistance. We know that this is a big issue. Most of the time we have different factors that are contributing to that, but in most cases, I like to stick with two. And of course, from those two, we can really expand different factors and different enablers of AMR development on a global scale. So we do understand that we're currently, as a matter of fact, AMR was considered to be the second factor, existential threat to humanity after climate change. And we understand that the drug-resistant infection is really threatening every one of us, and in some cases not equally, definitely. So if you look at the recent publication by the Lancet with the global burden of bacteria and microbial resistance in 2019, we do see that a lot of burden is coming from Africa with respect to deaths or burden of disease and also death, mortality associated with, and also directly related to AMR bacteria, which is from the map right here on the slide. You see Africa be at the center of that, and also some other parts of Asia, which are characterized by low, medium income countries. So if you look at CDC report, US CDC report on antimicrobial resistant threat, I'll be able to categorize different antimicrobial bacteria into urgent threat, serious threat, concerning threats, and as a matter of fact, they have a watch list or waiting list of new emerging AMR bacteria within US on a global scale. And of course, you look at this classification, you can look from African perspective, we see a lot of AMR bacteria being categorized as being urgent threats to serious threat. I mean, coupled with the fact that we're not, we're doing all we can with respect to surveillance, but the threat is really, really on that size of low and medium income country. So in most cases, when we talk about AMR within One Health interface, we know that we have people always point fingers to the animal domains, especially the livestock production, being contributing most of antimicrobial use and also driving most of AMR development and dissemination. But we do know that every part of the domain of One Health has a part to play. So whether it's the humans with different components, or whether it's the livestock, food animal, companion animal domain, and of course also everything that makes up the environment, whether aquaculture, runoffs from livestock production, wildlife, sewage, soil, and all other kind of pharmaceutical and industrial component contributing to development of AMR and also dissemination of AMR. And this relationship, we do believe, are really complex and intertwined. And just before I move forward with my presentation, we have to stop pointing fingers, accusing fingers to different domains, or most of the time livestock domains. So we need to understand that every domain of One Health has a part to play with the development and complexity of antimicrobial resistance. So while we're currently battling different threats with respect to AMR bacteria, it is important for us to also understand that We have a new emerging infectious disease, and of which we do know that about 21% of EID are drug-resistant microbes. I mean, the AMR word is not cutting us some slack. I mean, of course, we're battling the current threat, but we know that we have a lot of re-emerging or new emerging infectious disease, and of which of them about 21% AMR. So you look at this slide, you can see different hotspots, whether it's the zoonotic pathogen coming from wildlife. From the previous slide, we know that about 61% of that originates from wildlife. And of course, we see the zoonotic pathogen from non-wildlife from this slide. And of course, by the sea, if you look at the sea slide, we see that right here, some of the hotspots of emerging AMR drug-resistant microbes also coming from Africa, most especially the sub-Saharan Africa and some part of the Asian countries. And one thing we've seen, I mean, from this study that kind of look at this study, I'll be able to find that with the hotspot of emerging infectious disease have been associated with low socioeconomic status, human population density, and agricultural practices, and different ecological factors that are characterized by low, medium, and income countries. And so, which kind of points us in the right direction, the fact that even though the emerging infectious disease are out there, is being associated with different hotspots from low, medium, and income countries, especially sub-Saharan Africa. So we do know that it is important to talk about AMU, AMR, but we have to make sure we're speaking the right thing. We've seen people kind of, especially if you come to the North America, you know, be careful what you say with respect to saying that antimicrobials are resistant. But I like to say non-judicious use, indiscriminate use is actually contributing to resistance. And if you look at the different report out there, we can see that AMU is really increasing on a global scale, whether it's Africa, whether it's North America, whether it's Europe or different parts of the world. And that is really concerning. So no parts should be blamed, but every one component of different region of the world is really driving and contributing to this resistance. So we did a study using the GLASS data. We're looking at correlation between AMR and AMU on a global scale. And this is the result we find from our study. We could see from this study that we find a correlation between beta-lactam consumption as well as bloodstream beta-lactam resistance equal as well as Klebsiella. But the most important finding from this study is how the countries were classified with respect to AMU, AMR relationship. I mean, you look at all this, the four slides, the fourth chart right here, you will see the developed countries showing some low use, low AMR, right here, low use, low AMR, low use, low AMR, low use, low AMR for both fluoroquinolones and beta-lactam or third generation cephalosporin. But if you look at what we have on this side, we'll see high use, high resistance with low and medium income country, whether it's Ivory Coast, Fiji, Uganda, right here across the board. I mean, this is really very concerning for us. I mean, it's important for us to understand that even with AMU, AMR relationship, we'll see that you know, developing countries and low medium income countries that is contributing to most of the resistance that we see. This might be due to a lot of factors, but I pin that on the fact that developing countries have a grip on monitoring and surveillance, as well as a collection of data and monitoring prescriptions here and there, compared to developing countries, whereby in most cases we have antimicrobial access over the counter. And so this is really important finding, and it's also cause for concern. So on a global scale, with recent reports, like I showed the other time with the Lancet, we see that Africa, especially sub-Saharan Africa, is at the forefront of you know, death associated with AMR on a global scale. And of course, that's about 27.3 deaths per 100,000 on a global scale. I mean, this kind of shows to us that AMR is really eating Africa differently. compared to other parts of the world. So let's look at some of the case study of AMR out there that we can really be able to, say sometimes people kind of, they question when we talk about AMR, on a global scale or one aspect of it. But this is a perfect example that we see from a study that was conducted in Tanzania. I mean, right here, you will see the pattern of antimicrobial resistant development, both in livestock, companion animal, chickens, and water. I mean, of course, I didn't show the last slide, which is the wildlife, followed the same pattern of occurrence and development of AMR across different domains of One Health. I mean, this got to tell us that, it's still a problem. It's a problem. And we have to look at it holistically from One Health perspective. And of course, you look at the phylogenetic trees and also the relationship between different macros from different domains, and we see that there was no specific clustering of E. coli across all the domain right there from that report that was conducted in Tanzania. And of course, we can also look at different parts of the world that have also provide different evidence of transfer of antimicrobial resistance across one domain. And of course, this last slide shows us different transmission pathways, whether from humans to animals to humans, animals to environment, and vice versa across different domains. So when we talk about AMR being a problem at one interface, it's not an understatement, and we cannot beat that story too much. So it's still a problem out there for us. So again, you look at different reports again, whether the relationship between antimicrobial use and also development of antimicrobial resistance in whatever direction you might be looking at it from within the domain of One Health or across the domain of One Health. We see that AMU, indiscriminate use of that, is really correlating with development of resistance across different domains of One Health. So, I mean, let's talk about different impacts of AMR. I mean, from economic perspective, I'm sure a lot of us are familiar with the news report, and based on that, I mean, it's the projection is really very, very bleak. I mean, you look at what we have that by 2050, 10 million lives will be lost each year due to AMR, and of course, economically placing money on that cost on a global level about $100 trillion US. I mean, that's huge. That's huge for economy, especially for low, medium income countries, right? With very low gross domestic product. On an individual level, I mean, we've seen a lot of results out there, a lot of publications looking at the increased risk of therapeutic failure, antimicrobial escalation. You have increased length of stay, especially in human, also among the pet veterinary care. And we see that in most cases, you could have mortality due to antimicrobial resistant bacteria, and of course, increased continuous transmission across one domain. So let's talk about different drivers across different One Health. I mean, when we talk about One Health, like I mentioned before, we have the human domain, we have the animal domain, and environmental domain. So I like to pick the drivers from each domain, and then we'll look at it in depth. So from human domain, I think one drivers of AMR, and by extension, all most zoonotic pathogen and emerging infectious diseases, the global population is really increasing. I mean, it's estimated on a global scale, we'll have about 1.2% increase per year. And most of that is coming also from developing countries. And of course, like I showed from previous slide, we do know that EID events associated with drug-resistant macro being associated with human population density and growth. And so this one of the drivers of resistance, because with increased population, put a lot of pressure on both public health infrastructures. And of course, with that, there's every possibility of dissemination of AMR within the community and also within the healthcare system. So another drivers that, I cannot put here is that we can see that, on a global scale, 1 billion people are crossing borders each year. I mean, whether due to conflict, I mean, due to leisure, people travel for tourism, I mean, just, due to sheer migrations and on a different continent, or especially the developing countries, we see a lot of refugees coming to developing countries. And in most cases, from what we've seen in the literature, carrying along with them different infectious agents, of which AMR bacteria is part of that. And so with this migration, it's kind of accelerating and kind of increasing human, animal, and also animal product interaction, which create what we call a perfect microbial storm, and in most cases due to AMR bacteria. And of course, most of the time we do go for travel, you go for tourism. I mean, sometimes we go to food tourism, and we know what traveler's diarrhea is, and that's one of the common associated occurrence due to traveling, or especially for tourism to, most cases, low, medium, and income countries. And of course, we can also talk about war, terrorism, and conflict, which has plagued most developing countries. And of course, you look at a report coming out from UK and Russia, being a developing country, but still we know that there have been increased use of antimicrobial and also development of antimicrobial resistance across different war torn and also terrorism, and as well as conflict prone regions of the world. So another driver is that we are having a growing population of individuals, of people with greater susceptibility to infectious disease, right? You look at the chart on the right-hand side of my slide, we can see the reports that were recently presented by Lancet. We see that for both associated as well as attributable AMR mortality, we see a share of that is associated with senile population, old age, as well as senior citizens within different parts of the world. Good. So what we're seeing is that we're seeing a lot of community acquired as well as livestock acquired hospital infections, and of course we do know most of the escape pathogen are associated with that. And then again, we see that even with immunocompromised situation, we see a lot of comorbidity associated with immune status, like I mentioned, associated with most senior citizens all over the world, as well as those that have pre-existing situation like organ transplant and different immunodeficient situation like HIV. And of course, lastly, we see that poverty and social inequality have really contributed to that, which are very common in low, medium income countries due to low socioeconomic status, homelessness, drug abuse, and of course, displacement due to conflict and also terrorism, as well as war going on in most low, medium income countries. So let's look at the animal domain. Of course, we know that with international trade, transportation, there's every possibility of introduction of existing and new microbes with MDR potentials. I mean, the world is a global village, and of course, trade keeps going on. And also, it's very possible for transmission of that across different trade routes. And of course, we know that food safety is a bigger issue, of which AMR is part of it, whether it's from produce, whether it's from livestock and animal byproducts, or just during productions of different livestock and also different vegetables and produce. We do know that manure application can also introduce, without necessary bioremediation or reducing the microbes load within the fertilizer, can really contribute to dissemination of antimicrobial resistance. And of course, we know the importance of wildlife. In most cases, that animal and also environmental interface can introduce new and emerging infectious pathogen, of which we mentioned that AMR bacteria is part of that. And then, of course, we do have some cases of being pet lovers, occupational exposures, contact with the wildlife within, by encroaching into the wildlife population. Sometimes we come in contact with different bacteria, which can lead to, colonization and also transmission and dissemination of AMR bacteria across one interface. So when we talk about environmental interface, and of course we know that most of those factors are anthropogenic in nature. As human beings, most of the time we pollute our environment, wastewater, open defecations, runoff here and there, most of environmental degradation due to some severe weather conditions. I mean, sometimes we have livestock production waste running into the aquatic and also aquaculture environment. And of course, we know we do have environmental residue of antimicrobial resistance, which can lead to, development of resistance bacteria within the environment. And of course, we know within the environment, we have reservoir of AMR bacteria also. And then, of course, lastly, we do know that it is possible to have to pick up naked DNA from the environment, which we call environmental DNA. And of course, with different indiscriminate use of antimicrobial within the environment and also livestock environment can lead to a dissemination of resistance and maintenance of resistance and reservoir within the One Health interface. So when we talk about One Health dissemination, it's also important to also look at macro perspective. And of course, most of the time, this is what most people usually means when we talk about One Health or AMR and dissemination across One Health. We know microbes would like to survive, like we also want to survive. So we use antimicrobial because we like to treat ourselves from infections due to microbes. But we know within the microbe population, they also want to survive. So what do? They develop their own defense capacity. How do they do that? In most cases, they change their infectivity. They change their pathogenicity. They become more virulent. Or in most cases, they develop multi-drug resistance. And also, what do? They help different microbes by sharing different mobile genetic elements across different microbe populations. So I will talk about AMR across One Health, different drivers. I mean, I'd like to end by kind of provide some of the suggestions, mitigating strategies that we can really look at on an African perspective and also on a global level with respect to AMR. So we know that on a global scale right now, people are talking about developing national action plan against antimicrobial resistant bacteria and also different framework in which a different country can develop their own mitigation strategies. And so there's no way we can talk about addressing AMR across One Health interface without talking about policy, regulation of antimicrobial use. And of course, when we talk about One Health, we talk about it from local, regional, national, international, on a global scale. And so all hands needs to be on deck to be able to address the problem presented to us by development and dissemination of antimicrobial resistance. And of course, there's no way we can talk about different mitigation strategies without talking about necessity for us to develop new antimicrobial. I mean, that's a far-fetched, we do know, because development of antimicrobial, new drug antimicrobial is really very costly. I mean, new candidates, antibiotics are not out there, but we need to also look at developing new antimicrobial and also look at different alternatives, so plant-based alternative and different alternative strategies to antimicrobials within and across One Health interface. And of course, I do know that one of our speakers is going to talk about diagnostics. So we can't talk emphasize the need for new diagnostic state-of-the-art diagnostics as well as surveillance. And of course, there's need for us to educate ourselves and inform a change in our behavior with prescriptions, access to antimicrobials, and also the use of antimicrobial. Now, for mitigation strategies, it's important for us to know that behavioral modification, education, creating awareness is very, very important and go a long way against fight against antimicrobial resistance. So on a global scale right now, based on what I kind of shared the other time, that the interaction of AMR across One Health interface is really complex. And so right now on a global scale, people are started looking at integrated surveillance program. I mean, you look at that from US, Canada, even the European Union. So people are looking at how do we coordinate the sampling, the testing of different AMR bacteria across different domains of One Health, without looking or emphasize just one domain of One Health. I mean, you look at what we currently have, most emphasis have been placed on the livestock aspect of it. But right now, people are moving away from individual domain and start looking at monitoring surveillance across One Health interface. When I kind of look at this slide, the different initiative right now in Africa, I mean, which is really encouraging and very good. And we know we're doing what we can and we're in the right direction. And also with collaboration from developing countries like FEME Fund and different program instituted by UK, AID, to kind of support the monitoring and surveillance of antimicrobial resistance on a global scale and as well as within Africa. So this is really encouraging, and this is the way we need to go. Every hands needs to be on deck. Collaboratively, we need to come together, both at local, regional, and different country, and also on a continental level to be able to address the problem presented to us by AMR. So when we talk about what mitigation strategy, then right now the direction we're going is antimicrobial stewardship. And of course, some people do usually place emphasis on non-use. I mean, we're not really talking about non-use right now. I mean, the most important is how do we maximize the use of antimicrobial and also minimize the development of antimicrobial resistance. And of course, that relationship is really complex when we talk about antimicrobial stewardship. So practice guideline, whether it's a veterinary or human practices, infectious control, like I mentioned the other time when I started my presentation. And of course, we do know that monitoring surveillance is very important. Education, we can overemphasize the importance of education and behavioral modification. And of course, like I said the other time, regulations is very important. Policy development at different stages of the country, whether at the local level, regional, national level, as well as also on the continental level within Africa. So I throw in the slide to kind of look at Canada's story. You look at the slide. I mean, in mostly around 2005, Canada, through education and also awareness creation, was kind of talking to the poultry industry for voluntary withdrawal of septic for use. And we see that when they introduced that campaign, there's concomitant decline in antimicrobial use and resistant development in both livestock as well as also in humans. And so you look at 2007, 2 years after, when there was partial reinstitution of septic use, we see resistance concomitantly increasing. And so this tells us that, with education, awareness creation, introduction of campaigns, policies, regulations, sometimes also can help to kind of drive down and reduce development of antimicrobial resistant dissemination as well as transmission across pollinating efforts. So to kind of summarize my slide, I don't know the time, but just summarize the slide. We do know that AMR is a global problem and it's kind of cut across different interfaces. And we have different key drivers, and one aspect of one net domain cannot be blamed. Every part has a part to play and contributing. We see that on a global scale, the mortality and economic loss is really huge with the projection. And so it is important for us that we need to institute some mitigation strategies to kind of be able to fight against the development and transmission. So thank you very much.
Thank you very much, Dr. Babafela Awosile. That was wonderful. Thank you so much for the energy, for the time, and for the effort you put in place to make this stellar presentation on the subject matter of antimicrobial resistance. Colleagues, and for those who are just joining us, if you have any question you would like to ask Dr. Babafela Awosile, please we request that you just hang on a little bit. We'll have the Q&A session once everyone has made their presentation, and we'll ask the speakers collectively. I would like to share my screen right now to bring to the fore the next speaker for today. Please just give me a sec. Let me just put this in presentation mode. Please confirm if you can see my screen from your end.
Yes, we can see it. Yep.
Oh, nice, awesome, thank you. Okay, our next speaker for today is responsible for priority setting, knowledge management, open access, data sharing, and ensuring evidence is translated into policy and practice. He has worked in the Middle East and undertaken development consultancies in several African and Asian countries for the WHO, Oxfam, VSO, UNAIS, and DFID. He has a PhD in Global Health Research Policy from the University of Cambridge. He is the Manager of Research Policy for the Special Program for Research and Training in Tropical Disease at the World Health Organization. Ladies and gentlemen, without wasting any bit of our time, please join me in welcoming Dr. Rob Terry as he makes his presentation. Dr. Rob, we are very glad to have you. If you are ready, you can share your screen from your end. Thank you.
Very good. Thank you. So I'm just sharing the screen now.
If you can put on your
Okay.
camera too, that would be great.
Yeah, the camera is disabled. Somebody will have to turn it on for me.
Oh, really?
Yeah.
I'll do that right away.
Okay.
Perfect.
That seems to that's worked. Okay. So you can still see my slides.
Not yet.
Okay. Let's try again. All right. What about now? Yep.
Yes, we have it.
Okay,
Perfect.
excellent. Thank you. Okay, so I'm Rob Terry. I work in TDR, the Special Program for Tropical Disease Research and Training. And I'm going to talk about the impact of operational research as a tool to tackle antimicrobial resistance with a One Health approach. So this is really the take-home message, and that's from my colleague, Ronnie Zachariah, who runs this program in TDR. And it says in integrating research and communication skills in frontline workers in health, agriculture, and environment has enabled countries to unlock the data in their systems and move from being data rich to being information rich. So what is operational research training? Well, it's a program that was developed by Médecins Sans Frontières, the TB Union, and TDR, and we started in 2009. And what we're really focused on is research that uses local data to answer locally relevant questions. And the actual course is disease agnostic. We've used it with neglected tropical diseases, TB, HIV, and I'm going to focus today on antibiotic resistance and One Health. And what we're really trying to do here is provide research training to those frontline workers who may or may not have research experience. And in 2019, we added a new module to that training, which is about knowledge translation. So that's about how you communicate your research findings effectively, because we're not doing research for research's sake. We're doing research in order to influence and change policy and behavior. So here's a very simple case study just to explain what I'm talking about. This is from a district hospital in Kabul, and they were concerned they were an over-prescribing behavior at their hospital. And so operational research uses data that's already available, and in this case, that's hospital records. And what they found was that 6 out of 10 people leaving the hospital were leaving the hospital with antibiotics. And that's 2 times greater than what WHO would recommend. So after doing that piece of research, there were some recommendations made. And the implementation of those were to educate both the health staff, but also the community on rational antibiotic use, because sometimes it's the patients who are demanding antibiotics as much as we heard previously, incorrect prescription. After a 2-year period, there was a follow-up, and that's really important. It's about following up on those recommendations and seeing what their impact were. And in this case, we could see that prescription for outpatients had fallen back and into the WHO limits. So how do we organize this? It's a course that has sort of 4 elements to it. And perhaps the key one is at the top there, which is about engagement of local stakeholders to define local priorities. And as I said, what we do is we provide the training to conduct and publish operational research. And the reason we use publication is because it's a quality assurance tool. It's not publication for publication's sake. But having a research paper and working within a ministry can also be very good for one's career. And what we're trying to do here is build sustainable research capacity and put in place the structures within the Ministry of Health, Agriculture and Environment to actually understand and use evidence to inform decision making. And as I said, more recently, we've been doing work on enhancing the mechanisms for knowledge translation and uptake. And that means providing training in things like stakeholder analysis. So who needs to know how and in what form do they want to get that information? And so that means providing the research in a different format. It may well be a plain language summary. We call them evidence briefs. These are single side of A4, which provides the essential information, what we did, what we found, why that matters, and what are we going to do about it. And we even look at things like networking skills and how to present your work briefly, sometimes less than 30 seconds, if you were, say, at a conference and networking. The QR code there will take you to the website where you'll see lots of examples of this. So these modules normally take place, they're about a week long each, over an 8 to 12 month period. There may well be 12 projects. On each project, there may be a senior researcher and then a junior researcher. So we're trying to train as many people as we can. And we try as much as we can to stick to these milestones of 80%. And that means 80%, a minimum of 80% who start the course, finish the course, a minimum of 80% that finish the course, publish within the maximum of 18 months, and 80% of those papers, when we follow up them, can actually demonstrate there's been a change to policy and practice. So these are the countries that we've worked in, and I think, and I hope you can see quite a broad geographical spread there. And what that has meant that we've done over 100 courses. That's trained nearly more than 1,000 people, 900 publications. And the sustainability here is quite high, because what we do find in 50% of the cases is that once we are no longer involved, the research teams continue at least one more round of research themselves. So that's quite important. This slide just shows you the complexity of the partnerships that we work with in those countries that I mentioned earlier. So here's a bit more of a case study, and I think this actually addresses one of the questions that's already in the Q&A. So this is Dr. Leno. He's the one of the two working vets in the Ministry of Agriculture there in Sierra Leone, and this really highlights the importance of surveillance data. And what we did here were 3 rounds of research, so 3 separate pieces of research. The first was try to understand what surveillance data exists and how much of quality that it has. The second round was following that study, how can we measure the impact of the recommendations that were made? And then how do we monitor that into the future and sort of make this effort more sustainable? So if we look at Sierra Leone today, for livestock data, all of the districts, all 14 of the districts now report on livestock data, and that includes the usage of antibiotics within that system. And it was only 3 of the districts in 2017 when the research started. We're now at about 88% of weekly reports being received, and that was only at 1% in 2017. So what we see is if we embed research into the system, what we find is that the quality of the surveillance data starts to improve. And it's only if we have quality in surveillance data can we actually start to get a handle and a downward pressure on antimicrobial use. And these are the words of Leno himself about the dangers of not being able to keep a downward pressure on antibiotic use. Another case study we've just completed more recently in Ghana. Again, 3 rounds of research. First of all, identifying the difficulty and the problem and the challenges, making recommendations about those. We had 12 projects. 5 were hospital-based. Another was looking at sampling different types of drinking water and measuring the bacterial load in there and assessing the resistance of those bacteria. Looking at a very simple treatment for salad, so using salt or permanganate or combination solutions to actually wash salads so that you can actually remove bacteria from the food chain. 2 studies looking at pig production, 1 antibiotic use within pig production, but also, as we heard earlier, the looking at the slurry or the runoff from that. Is that a system for entering the environment with resistant bacteria? And finally, looking at 2 seafood processing plants where the effluent, which is very high in protein, is that a source of bacteria? What's the bacterial load? And what is the resistance within that? That's all been published in this special edition. The URL is there and the inevitable QR code. So just taking that experience, what do we find? Why is research such a useful tool? And I think we've got the strategic areas on the one side, and then we have the enabling factor. And I think probably the key one, of course, is align your research with national priorities. And in the Ghana sense, all of the studies, before they were undertaken, were cleared and given the green light by the National AMR Committee. And another really key thing is engaging end users early and continuously so that they were involved throughout the whole process, so that when the recommendations come, they are things that they recognize, they are things that they own, and they are things that they know they can action. We try as much as possible to make the operational research timely and high quality, because with operational research, the outcome is time limited. We need to know what the system is telling us within the last 6 months, not 4 or 5 years ago. And dissemination is becoming so important. Being able to tell the story in ways that people hear it and act on it. And sustainable building capacity on research, again, shows that if we return to this topic again more than once, we have a greater chance of actually demonstrating some success. So just something new on the communication side, we have actually now turned that into a free online course that you can do. We cover things, like I said, stakeholder mapping, writing evidence briefs, different forms of video presentation, including what we call a lightning presentation. So actually presenting your research in less than 3 minutes. In the face-to-face course, we've had 150 people have been trained, and I just looked last week, we've had more than 2,000 people register for the online course, and 140 or more than that have gone through it and had their WHO certificate of completion issued. And again, the inevitable QR code there will help you find that training course on the TDR website. So I leave you with this quote from the CMO in Sierra Leone. And I think it says, if research is to have impact and improve outcomes, it must be locally relevant and the findings actionable to shape policy and/or practice. And structured operational research training is well designed and invaluable for this purpose. So again, lots of examples of the papers that have come out of this particular research program, the evidence briefs, those little summaries I talked about, and even the videos are all available on the TDR website. And there is the link, and these slides will be shared, I'm sure. And then just some acknowledgements for people that have contributed to this presentation. Thank you very much.
Thank you very much, Dr. Rob. That was wonderful. We are very glad that you could join us to make this presentation. Very enlightening, ladies and gentlemen. If you have any question with respect to the presentation of Dr. Rob, kindly drop it in the Q&A box and we'll attend to it when the time for question and answer comes. Sincere apologies to everyone. For time's sake, we are going to extend the meeting for 20 minutes. So please, we request that you bear with us and stay connected with us so that you can learn from the resource persons that are yet to speak. So without further ado, I want to quickly introduce our next speaker to us. Let me just share my screen real quick, and please let me know once you can see my screen.
Yeah, that's it.
Okay, great. Okay, our next and final speaker for today is the Medical Affairs Manager for Anglophone Africa at Biomirrors, a leading scientific and medical engagement. He is leading scientific and medical engagement across East, West, and Southern Africa. He is a medical doctor and public health specialist with experience in antimicrobial stewardship, serving on Kenya's NASIC Technical Working Group on Antimicrobial Stewardship since 2019 and contributing to the 2020 National Antimicrobial Stewardship Guidelines. He was also a co-investigator in Kenya's 2021 Global Point Prevalence Survey on antimicrobial use and resistance. And final speaker for today holds, he is a graduate from the University of Nairobi and also holds a postgraduate diploma in tropical medicine and global health and a Master of Science in Public Health from the London School of Health and Tropical Medicine. Distinguished ladies and gentlemen, without wasting any bit of our time, please join me in welcoming Dr. Kiplangat Sigai as he makes his presentation. Dr. Kip, if you are ready, we are ready. You can share your screen from your end. Thank you.
All right. Thank you, Ohemo, and thank you everyone for this kind introduction, and welcome to this excellent meeting today. I hope I'm audible as I project my screen, sorry. All good, Ohemo?
Yes, all good. We can hear you loud and clear.
All right. Thank you so much. And also thank you so much to the two previous presenters for setting an excellent foundation for today's discussion. And I'll go straight into my topic, which is breaking the resistance and trying to see how we can have diagnostics empower our fight against AMR in Africa. So I'll go straight into the discussion, and some of this might be a little bit of a repetition, so I'll try and move a little bit faster. We know the latest statistics on AMR from a global perspective, and the main highlight on this slide is to show that, Africa does continue to have a high burden of HIV, AIDS, and malaria, but from 2019 data, it's now being overtaken by AMR quite significantly, and it's something that we need to now put at the top of our priorities, the same way we did when we started dealing with HIV, AIDS, malaria, and other infectious diseases. And if we look at this same data and narrow down to the impact in terms of regional spread across the world, we know that Africa continues to suffer the highest burden of antimicrobial resistance. And if we dive deeper into some of the causes, which have, of course, been highlighted by previous speakers, I just want to narrow down that one of the issues that was raised is the scarcity of lab infrastructure that makes microbiology testing unavailable, inaccessible, or unreliable. I can add that to inform treatment, to stop antibiotics, or even to narrow down antibiotics. And this is what is driving a higher burden in sub-Saharan Africa, particularly in our region, in our context. And it's estimated that 1 in 5 of deaths linked to resistance was actually in children under 5. So this is something that we also need to look at from a child mortality perspective. We had this project run by various partners called the MAP project, Mapping Antimicrobial Resistance and Consumption across Africa. They looked at a couple of countries, about 14 of them, and this they were able to highlight some of the high impact of AMR in our region. So 1.3 million deaths attributed to AMR in 2019, $100 trillion lost global production by 2050 if we continue at the same trend. And then, of course, Africa has the highest mortality from AMR in the world, having a rate of 27.3 per 100,000 being attributed to AMR. And if we look at a specific segment of this report that looks at laboratory diagnosis, we see that a paltry 1.3% of laboratories across these 14 countries shown on the slide are actually performing any bacteriological testing. And these are diverse countries representing a mix of socioeconomic backgrounds across our continent. And 1.3% is really something that we should not be having, even though we do know we have challenges. And if you go deeper, of the 205 labs that were sampled, 26% of them were using any form of electronic LIS, lab information system. 80% were performing less than 1,000 AST or antimicrobial susceptibility tests per year. Only 23% were ISO accredited for bacteriology testing, and only 20% were using automated methods for pathogen identification, as well as for antimicrobial susceptibility testing. So the situation is quite dire, and this is data from our continent and a quite recent project. I think the first publication came out in 2023. So if we continue, and that's a dire presentation of the situation. However, we have some initiatives that have been driven at a global level, which have also come down to the local level here in Africa. And obviously, we are all familiar with the Global Action Plan on AMR launched by the WHO. And this plan has enabled countries to have their own action plans. We know implementation of these action plans varies across our continent, but I must say, I think we can say there has been some trajectory. Even having a plan is a good starting point. And then moving on towards implementation is where we still see a lot of variation. Back in 2023, the WHO actually issued a very high-level recommendation where they recognized the critical role of rapid and accurate diagnostics to combat AMR by guiding correct management of infections and appropriate use of new as well as existing antimicrobials, of course, through improved antimicrobial stewardship and surveillance. So a very high-level declaration from the WHO. In terms of it trickling down 2 years later across our continent, as obviously that varies depending on various factors. And then, of course, last year, just over a year ago, we had the high-level meeting on AMR at the UN General Assembly. And I think this was very important to have AMR elevated to that level of a discussion. And obviously, many areas of AMR were discussed, and diagnostics was obviously one of them. And hopefully some actions coming out of that will reflect in progress. So diagnostics is critical, and it's estimated that in an ideal world, and I want to emphasize in an ideal world, diagnostics should guide 70% of clinical decisions. However, what we know in our setting, and I've presented some of that earlier, it is probably less than 10% or 20% to 30% in the best of centers. And so we have a challenge. And if you look at the continuum of infection, diagnostics should play a role across the spectrum, particularly when you have symptomatic patients and you want to obviously monitor the treatment, institute treatment, as well as modify it. So it's important that we, in an ideal world, we should be aiming for 70%. But I think in our setting, this is definitely not happening unless in very specialized cases, highly resourced countries or countries where you have top research labs and so on. So at the WHO level, there has been progress in making diagnostics as essential as medicines for a very long time. And I think those who are clinicians in the audience, you will agree with me that we've had a great focus on, at least has had 1 or 2 versions done, and this keep being updated. Again, implementation of that is a challenge. When it comes to diagnostic list, even at WHO level, this is pretty recent. As you can see, we are now at the 4th version, the most recent one, 2023. And this is a good step by WHO because now we have something, a framework that any country across the world can use. Some countries have actually launched their own essential drug list. My home country of Kenya, I can mention, has at least had version 1. But it does vary across the continent. And this is something we need to look at a little bit more seriously because once you have an essential list, it really informs prioritization of resources, prioritization of, what new solutions are brought to a hospital. And it creates a framework where, you can actually pitch to all the senior leadership that if we don't have this diagnostic, then we are really not practicing ideal medicine. So this is something that I challenge the audience, and, you can share your thoughts on your various backgrounds where this the issue around the diagnostic list and in your various countries, how it is being implemented. And so back to the bedside of the patient, and we know that in the day-to-day practice of medicine, there is a challenge, where when you're treating an infection, you want to balance short-term objectives where we must institute broad-spectrum antibiotics therapy, especially when the patient is critically ill and you want them to, you must treat them. And in that space, you're obviously trying to maximize therapeutic benefit while minimizing the side effects. But in the long term, we want to prevent AMR. And here we must then adjust this broad spectrum antibiotic to either a different antibiotic, depending on the result, or narrow it down a little bit more so that we're able to preserve the broader spectrum for the patients who really need it. And the challenge we face is in many cases, patients end up with the broad spectrum antibiotics for too long. So there's nothing wrong with a broad spectrum antibiotic. The challenge is how long does the patient stay on the broad spectrum antibiotic before it's narrowed down or even stopped, depending on the clinical cause and what is discovered about the patient. And so diagnostics obviously are not the only thing, but they are very critical in helping us shift from this empiric to targeted therapy. Obviously, there are other things that are important, but I think we can emphasize that without diagnostics, you really cannot make that decision confidently. The days of making decisions based on the clinical presentation of the patient only are slowly fading away. We need to move more towards a focused approach, looking at the evidence and really treating what is there. And so we have various diagnostics, and these vary from the rapid tests all the way to advanced PCR platforms that do multiplex readouts, and all the way to the next generation of sequencing and all these other things that are coming on board. Obviously, we're not saying every facility must have everything, but at the end of the day, some level of diagnostics must be used at every level of care of the patient so that we're able to narrow down the treatment appropriately. And I want to emphasize that we've had a lot of innovation in technology, especially those who are in the laboratory medicine space. And I know some of them are in the audience. They know that, what was there 5-10 years ago, we have much more advanced equipment, much more accurate equipment, and equipment that is really more user-friendly, both at the lab level and also at the clinical level, where the results are coming out with a lower turnaround time. So again, if we look at the African situation and where diagnostics can play a pivotal role, again, from the ASLM, the African Society for Lab Medicine, I think this was a discussion they had last year. They really focused on 3 points that are really crucial. Number one, diagnostics will help us provide evidence because the data generated in the lab around pathogen drug sensitivity enables us to, first of all, treat the patient appropriately, but also formulate ideal policies that will help us implement, in fact, effective control of AMR. The second key point is obviously surveillance. If you then test regularly and monitor sensitivity of pathogens across a country, across sub-country levels, and even institutional level, you're able to understand the trends in your setting. And this, you come up with antibiograms that help you with, having the right empiric antibiotics, and also informing treatment choices at the pharmacy level. And also you're able to monitor trends of resistance and intervene appropriately. And then, of course, capacity building. If the lab is having very basic diagnostics or no diagnostics, the lab personnel are really not able to do much in terms of what an ideal lab should do. And, SLM has committed to enhance the capacity of labs across Africa so that they're able to detect the most common pathogens, and especially the resistant ones, so that we can have effective actions instituted. I saw this publication came out, I think 2-3 months ago, and really this summarizes the issue. There is, amongst the many reasons that are leading to AMR, and have been alluded by the previous speakers, diagnostic gap is really one of them that is fueling this scourge. And if we do not act right now to improve our diagnostic practice, we really risk losing the battle and really having a crisis that's out of control. We know there are actions that have been done. It's not all doom and gloom. The Africa CDC has led quite a number of initiatives on diagnostic capacity building. And one of them has even focused on genomic surveillance, which is a very important new and emerging area of focus. We also have the WHO. I saw this where they're focusing on diagnostic initiatives at the WHO level. And I think countries can just adopt what these supranational bodies have done in terms of creating a framework of action and then scaling it in the countries as per the priorities of that particular country. So diagnostic stewardship is very critical. And diagnostic stewardship now looks at diagnostics and says, which diagnostic test is the right one? And after I do that test, how do I interpret that the correct way? Because again, it's not just about doing a test and treating based on the test. You have to interpret it in the context of the patient, looking at many other issues affecting that particular patient. And then the correct diagnostic done at the right time. I already alluded to this. You have everything from rapid tests all the way to advanced tests. Which test will I use at a particular time? So stewardship means we also want to preserve our diagnostic tools to be used the right way. We don't just want to say, the patient has walked in and I'm going to order a battery of tests just because the patient either can afford or they're available to me. And this kind of stewardship really builds into antimicrobial stewardship, because on the clinical side, the clinician is able, as well as a pharmacist, I should add, is able to give the right drug for the right patient at the right dose and for the right duration, okay? And so it's very important that we have the right diagnostics, but we also steward these diagnostic tools. I'll close just by highlighting a few partnerships that we've done as a company across the world and obviously narrow it focusing on Africa. So as a company, we are in diagnostics mainly, and our focus is infectious disease diagnostics. We have immunoassay, we have molecular biology, which is PCR, and we have microbiology. We've supported a lot of capacity building, both at the lab level and also at the clinical level. And we have organized various activities. We've supported conferences, symposia, and so on. And we also maintain an online resource, which I'm showing on this slide, which is available freely to anyone who wants to learn more about diagnostics, and especially those affecting key infectious disease areas. So it's available to anyone, and all the resources can be downloaded by anyone. We've also supported the Global Point Prevalence Survey. And I think for those of us here who are in the AMR space, we know about point prevalence surveys, and many are available out there. So as bioMérieux, we partnered with the University of Antwerp over 10 years ago to support the development of the Global Point Prevalence Survey. Again, this is an initiative that you can find online. All the protocols are available for free, the data collection tool, and any hospital at any time can log in and actually start the project because you have the protocol, you have the resources, and we also have an online data analysis tool that helps you analyze the data at your level, and also the University of Antwerp can send you a report based on the data you've submitted. So this is something, again, available to anyone. And obviously, we know what PPSs do. They help us support our AMS activities. PPSs are quick, they're easy, they obviously have their drawbacks, but it's one way of quickly understanding the situation at a facility level. And then lastly, I think some of you are familiar with the Fleming Fund. So bioMérieux was one of the partners in supporting equipping reference labs in Africa and Asia with specific diagnostic tools. And the list of countries that we supported in Africa are listed there. We know that unfortunately the Fleming Fund is coming to a close, but I think just what we have been able to achieve by equipping some of these reference labs with this equipment has enabled these countries to improve their surveillance, to improve their capacity, and we are here to always support even after the Fleming Fund concludes its support. So take-home message at this point, we know that AMR is a global threat and a local reality with the highest global mortality in Africa, something that we must really take keen notice of. Antimicrobial stewardship is broad and has many elements, but diagnostics is key and must be prioritized, especially in Africa, where, as you've seen, we are not having the kind of diagnostic infrastructure that is ideal. Diagnostic innovation continues to give us new technologies that are improving time to result, improving accuracy, and many of these innovations can be launched and scaled up in Africa. We have solutions that are available across various hospitals in Africa, both public, private, and we are happy to support when needed. And then lastly, we need to continue partnerships and collaboration across the One Health ecosystem to improve antimicrobial stewardship. And I want to end by emphasizing we need to prioritize AMR and diagnostics, and we need to look for more local resources because we know what has happened with the changes in the funding landscape. And it's good to see governments, and I want to salute certain governments in Africa because we've seen that, who have actually prioritized diagnostics. Some of them have reached out to even companies like us directly to equip 5, 10, 15 hospitals. And, we're able to engage and support these initiatives. So we must look for local resources. External resources will always be needed because of our situation, but we should make the external resources less of focus and more of our local resources. And with that, I want to end with a quote from our founder of Biomerieux: "Without diagnostics, medicine is blind." And I thank you all for your attention, and I hand over back to Hemo.
Thank you very much, Dr. Kip. Indeed, without diagnostics, medicine is blind. Thank you so very much for your time and for the effort you have made in preparing and also being available to present this great presentation to our audience. Ladies and gentlemen, if you are just joining us, this is the World AMR Awareness Week webinar put together by the Antimicrobial Resistance Knowledge Hub and Community of Practice of the Global Health Network. Today, 18th November 2025. We've had 3 wonderful speakers and they've done justice to their presentation. And now it is time for us to take questions, and give responses to whatever question that you might have. I really want to plead with you. I know we have stayed longer than planned. Please bear with us. We really want to make sure that everybody, makes their presentation and everyone is carried along in all of in all that they were assigned to do. And the speakers have done really well. So it's up to you now to ask your question. I know so well. I looked at the Q&A box and a few persons dropped their questions and they mentioned the name to whom the question was assigned, and the resource persons took their time to answer a couple of those questions. So if there's anyone that has not been answered, for time's sake, I'll just take 1 or 2 so that we can actually move on. Our resource person have other engagement. This is the World AMR Awareness Week and lots of on-site and online activities, and they need to catch up, and we also have to catch up with some other activities as well. So please bear with us. If we don't take your question, it doesn't mean that we neglect your question. It simply shows that we are pressed for time and we just want to cover up for the time where necessary. Please find a place in your heart to bear with us and let us fly with what we have. So the first question that I have here is coming from Isaac, and Kekeshan, I'll be happy if you can spotlight all of the resource persons so that we can have their feedback. Isaac is asking, thank you, Dr. Terry, for your presentation. What are some requirements one must have in order to participate in TDR research to contribute to the fight against antimicrobial resistance? Very briefly, Dr. Rob, please.
Okay, well, briefly, it starts at the country level, actually, because, as I said, the key element of this program is identifying locally relevant questions. So in most of the countries where we've worked, there's been a conversation that starts with either the Ministry of Health, Agriculture or Environment and the WHO country office, and then we take it from there. So I think that's the briefest I can answer that.
Awesome. Thank you so much. That's great. Okay, so the next question is, Dr. Babafela, I saw one question that was, meant for you. Okay, so this is also from Isaac as well. Isaac is also asking, I would like to know if Africa has its own goal to tackle AMR collectively by 2050. Also, do you have any idea if our farmers are cooperating with researchers in making sure the researchers have a more informed data that will enhance our knowledge in combating antimicrobial resistance? That's coming from Isaac. Dr. Babafela, please.
Right. Thank you, Isaac, for your question. I think different countries have different and also national action plans, and I'm sure hands are on deck to have this spread over time. But I mean, based on what we kind of expect, collaboration was very important to actually achieve all this. I mean, we need to have structures, I mean, on ground to be able to do that. And I think based on the previous speaker has mentioned, funding, it would be an issue to do that right now and get to where we need to be. But most of the research out there is maybe individual researchers, but we need a collaborative, organized structure, maybe at governmental level, to be able to do all this. I mean, there are scanty of data here and there, especially that goes to WHO glass. But of course, with more structured collection of those information, I think we'll get there when the time right. But right now, maybe with whatever data that we have, we make use of it and kind of encourage continuous collection of that data to meet the goal by 2050.
All right. Thank you so much. Diana is asking, Dr. Kip, this is for you. With your level of experience in antimicrobial stewardship, have you ever come across a situation in which a patient result showed that resistance has been built against all available antibiotics at a particular facility? If yes, what were your interventions to ensure that the patient received the best healthcare outcome in this situation?
Okay, so thank you, Diana, for the question. So we encounter this a lot, and I want to give some experiences from recent presentations. I myself am not in the front line, but I work, of course, with a lot of specialists who are. And with the automated antimicrobial susceptibility testing equipment we have, sometimes the labs actually report more than they should. Let's put it that way, because ideally, certain bacteria are not supposed to even, we know they have inherent resistance to certain antimicrobials, yet the report from the lab will actually show a full list of antimicrobials tested for that particular pathogen or microbe. So the first thing is there should be good practice to only report what is relevant for the clinicians, because sometimes this actually scares people, yet it may or may not be relevant. Now, obviously, we do know we have MDROs in our setting, and I want to pick from a very recent presentation where one of the infectious disease specialists insisted that when we get this kind of reports, it's also important to look at the clinical picture of the patient, and then look at what is available before you make any changes. And then in some cases, and this might be a little bit controversial because it's expensive, in certain cases, there should be a genomic analysis of the resistance, because that helps you really characterize what's happening. So again, maybe the summary of this is to say to Diana that we should also empower our facilities to have access to clinical microbiologists and infectious disease specialists. Now, we know this might not be available to everyone, but with telemedicine and even visiting consultants, we've seen it work even in remote areas where certain cases really, before people get stuck, they should be able to engage a clinical microbiologist and an infectious disease specialist to have that discussion, because they have the local context and knowledge to give the best way forward. So that will be my response, and I welcome any other feedback from anyone. Thank you.
All right, thank you so much. So finally, this will be the last question we are going to take for today, so that we can catch up with the other engagement that we have. In many African countries, and this question is for the three of you. Every one of you, have worked in the African continent. You've led projects and programs in different spheres. So this person is asking, in many African countries, regulations surrounding the sales and use of antibiotics are weak or not adequately enforced. Over-the-counter availability of antibiotics without prescription is common, and this possibly contributes to inappropriate use and the rise of microbial resistance. What could be the intervention or recommendation from you guys to those African countries encountering this problem to help improve their capabilities? Dr. Babafela, you spoke on the African perspectives. I was wondering what your thoughts on this particular question. Then I jump to Dr. Rob and then Kip, and we draw the curtain.
Right. I mean, thank you for the questions. I mean, I think it's kind of very important to have structures. I mean, I keep going back to structure because that's what we've seen in other developed countries that have been on top of the situation, especially at the European level, where they have a lot of, regulations, monitoring. I mean, right now, I mean, in some of the European countries, for every 1 milligram, you have to record it. I mean, so it's easier to track that. And of course, that's what I'll say about having the structure at governmental level. And then from there, we need a lot of awareness creation. I mean, I keep saying that education is very important. We need to create enough awareness, make the shout, I mean, like we're doing in this meeting, to raise the awareness and talk about the problem of AMR. And then I think we go from there and just educate the people, whether they through the print media, through online media, goes to participatory level with at the village level to kind of intimate on the danger of antimicrobial resistance. So I'll yield for other speakers to provide their own view.
All right, Rob, what's your take on this?
Yeah, it's a common problem, and I think without strong regulation, it's quite hard to get a handle on small shops, usually over-the-counter, selling antibiotics. One project that has tried to counter this is accepting that you can't stop the sale. You can provide training to the shopkeepers and diagnostics, point-of-care diagnostics, so that in some cases you can try to reduce the amount of antibiotics that are being sold inappropriately. So, for example, a child presenting with a fever, which is actually malaria, and therefore, antibiotic use is not possible. So that kind of additional education that Dr. Babafela was talking about has had some effect. But yeah, I think without having strong regulation, it's going to be a real problem, I have to say.
Right, thank you, Dr. Rob. Keep final thought from you on this.
Yeah, so I think my two colleagues have summarized it quite well. We definitely need regulation. In many countries, the regulation actually exists. You'll find, and I can use my home country of Kenya, there is a regulation. It clearly says antibiotics should not be prescribed without a prescription and so on. But the enforcement is where we fail. And speaking about enforcement, we had a debate some time back, and we said probably the pharmacy regulator needs to find a way to include this in renewal of registration of pharmacies. It might be complicated, I don't know, but one way is just to see how much antimicrobial use was there. And, it might be subjective. People will say, yes, I saw patients and I thought they had an infection that was bacterial, but still some form of enforcement at the level of renewal of licenses needs to be explored. That's the only thing I can add to what my two colleagues have said. And I leave it as a debate. Thank you.
All right, thank you so very much, Dr. Kip. Thank you, Dr. Babafela, and thank you, Dr. Rob Terry, for your time and your presentation. We really do appreciate this. Words are not enough to express how grateful we are to have incredible colleagues and professionals like you on the call to make your presentation on the subject matter that has been given to you. Ladies and gentlemen, this is where we are going to draw the curtain today. Want to say thank you so much for making our time to be part of this. Tomorrow is going to be another day. Today we focus on Africa. Tomorrow we are going to be focusing on the Asian strategies to tackle antimicrobial resistance across human, animal, and environmental health. You can scan this the QR code on the screen in order for you to register for that event. If you haven't, the event is free of charge for everyone to attend and to learn and to reason together with professionals in the field of antimicrobial resistance. I really want to appreciate all of you for coming, and we look forward to making this recording available on the AMR Knowledge Hub of the Global Health Network for your reference, for your use, and so that you can reference it and look at the presentation that all the speakers have made. So I'm just going to stop here and allow my colleague Kakashian to share a single slide from my end, and then after that, I think that is going to be the end from my side. Dr. Rob, thank you so much for your presence. Thank you, Dr. Babafela. I know it is very, very early in the US at the moment. I think a couple of minutes to 5 or so, but you decided to avail us. We took away your sleep, and we are grateful that you made this possible. Thank you so much, everyone. Thank you, colleagues. Thank you, resource persons. Thank you, member of panel, and for joining. From all of us at the Global Health Network, we are very grateful, and we look forward to seeing you tomorrow, which is going to be the second day for the webinar series. Adam, any comment from you as we close?
No, nothing from me. Just to say, yes, absolutely. Do please join us tomorrow. Great to see you all again.
Okay. Thank you, everyone. Have a wonderful day, and we'll see you tomorrow. Bye for now.
Thank you.
Thank you. Bye-bye.